Dear Chairman, thanks for your invitation. The topic of my presentation is the Definition 2 trial. This is my disclosure. So far, there are 4 major randomized clinical trials comparing provisional stenting technique with different kinds of two-stent technique. Of them, Cactus, BBC1, and DK Quash 2 study compared provisional stenting technique with classic quash, all kinds of two-stent technique, or DK quash technique. At 6 months to 1 year follow-up, there was no significant difference in MACE between two groups. But in our DK quash 2 study, we provided the significant reduction of tight lesion revascularization (TLR) by DK quash. For these 3 studies, both left main and non-left main bifurcation lesions were included. However, in DK quash 5 study, which compared DK quash with provisional stenting technique, only for distal left main Medina 111 and 011, 2 kinds of true coronary bifurcation lesion. At 1 year follow-up, the primary endpoint, tight lesion failure, was reduced very significantly by DK quash technique. From the table you can see, in Cactus and the BBC1 study, patients with MI, CTO lesion, or distal left main bifurcation lesion were excluded from these 2 studies. However, in our DK quash 2 and DK quash 5 study, patients with acute myocardial infarction, CTO, and left main distal bifurcation lesion were also included in these 2 studies. On the other hand, the side branch lesion length was only 5 mm from Cactus study, which was not reported from BBC1. And the side branch lesion length was around 15.1 mm in our DK quash 2 and 16.4 mm in our DK quash 5 study. Also, there was significant difference in terms of the main vessel lesion length between Cactus study and the DK quash 2 or DK quash 5 study. However, the question is that even DK quash 2 study looks the lesion complexity was to be enhanced, but similar to Cactus and the BBC1 study, there was no significant difference too in terms of the MACE between provisional and the DK. On the other hand, in our DK quash 5 study, DK quash was confirmed to be superior to provisional stenting technique. So from this basic comparison of 4 different clinical trials, so probably lesion location, for example, left main versus non-left main bifurcation lesion, or the angiographic variables as well as clinical variables contributed to the occurrence of clinical events. So far, there was no any universal definition criteria to separate simple from complex bifurcation lesion. For this, in 2015, we studied to establish our new criteria from study arm with 1,550 patients with all kinds of bifurcation lesion. After that, the new criteria were testified in another validation group with 3,660 patients with all bifurcation lesion. Finally, we got for Medina 111 and 011, 2 kinds of bifurcation lesion with side branch diameter minimal 2.5 mm. We created 2 major criteria, either for distal left main or non-left main bifurcation lesion. Also, we provided 6 minor criteria. For distal left main bifurcation lesion, side branch lesion length minimal 10 mm and side branch diameter stenosis minimal 70% was the major criteria. So 1 major criteria plus any 2 minor criteria lesion could be defined as complex bifurcation lesions. So this is the arms of the Definition 2 trial to compare the treatment effect between provisional and two-stent strategies in patients with real complex coronary bifurcation lesion defined by definition criteria. These are inclusion and exclusion criteria. Particularly, patients with acute myocardial infarction older than 24 hours were also included in the study. Only Medina 111 and 011, 2 true coronary bifurcation lesions were studied. The assumption of the study was that the 1-year TF rate was around 14% after provisional and 7% after systematic two-stent strategy. The primary endpoint was the tight lesion failure (TLF). Finally, a total of 660 patients was required. This is study flowchart to show to show the randomization of 660 patients into provisional and two-stent group. This study was conducted at 49 international centers. So the safety endpoint was stent thrombosis at 12 months follow-up. Angiography follow-up was scheduled at 13 months, but it was optional. So table show no significant difference in terms of the clinical characteristics between two groups. However, patient with acute myocardial infarction older than 24 hours was reported in 22% in both groups. Regarding lesion characteristics, almost 28% of bifurcation lesion localized as a distal left main bifurcation lesion. Most could be classified by Medina 111 true coronary bifurcation lesions. Most of the procedures were performed through radial approach because of the very severely diseased side branch. So in the provisional group, side branch pretreatment was required in 46% of the patients. In the two-stent group, DK quash technique was most popularly used in 77.8% of the patients compared to 17.9% of Q-Law stent technique. In the provisional group, the crossover rate from provisional with 1 to provisional with two-stent was 22.5%, mostly used with TAP technique. At 1 year follow-up, the Kaplan-Meier survival curve showed very early separation between two groups, majorly because of the high rate of tidal vessel myocardial infarction in the provisional group compared to two-stent group. After 6 to 7 months follow-up, so the increase of TAR induced further separation of two curves. Finally, at 1 year follow-up, the TF rate primary endpoint was 11.4% in the provisional group, significantly different to 6.1% in the two-stent group. However, there was no significant difference in terms of the secondary endpoint, including all-cause death, cardiac death, definite stent thrombosis between two groups. So finally, in conclusion, systematic two-stent has less rate 1 year TLF. For patients with definition criteria defined complex coronary bifurcation lesions, compared to provisional approach, mainly driven by the reductions of tidal vessel myocardial infarction and clinically driven TLR. However, no significant difference in terms of the stent thrombosis between two groups. Because DK quash was most popularly used in the two-stent group, our finding may suggest the benefit of DK quash for complex coronary bifurcation lesion defined by definition criteria. Finally, the underlying mechanisms for the increased target vessel myocardial infarction after provisional stenting technique are still unclear, and further study is warranted. Thanks for your attention.